Indication. LENVIMA is indicated for the first-line treatment of patients with unresectable hepatocellular carcinoma, HCC. Summary of warnings and precautions with LENVIMA. Adverse reactions, some of which can be serious or fatal, may occur with LENVIMA, including hypertension, cardiac dysfunction, arterial thromboembolic events, hepatotoxicity, renal failure or impairment, proteinuria, diarrhea, fistula formation, and gastrointestinal perforation, QT interval prolongation, hypocalcemia, reversible posterior leukoencephalopathy syndrome, hemorrhagic events, impairment of thyroid-stimulating hormone, suppression and thyroid dysfunction, impaired wound healing, osteonecrosis of the jaw, and embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to pregnant women. Females of reproductive potential should be advised to use effective contraception. Based on the severity of the adverse reaction, LENVIMA should be interrupted, reduced, and/or discontinued.
Hi everyone, I'm Dr. Edward Kim. I'm an Associate Professor of Medicine in the Division of Hematology, Oncology at UC Davis Comprehensive Cancer Center in Sacramento, California. I'm joined today by Alana Rothman. Alana is a Nurse Practitioner Supervisor in the Division of Hematology and Oncology at UC Davis Comprehensive Cancer Center in Sacramento, California. Alana, thanks for joining me.
My pleasure, Dr. Kim. I'm happy to be here.
Please listen for additional safety information at the end of this video and access the prescribing information on the website. In REFLECT, the most common adverse reactions, greater than or equal to 20%, observed in LENVIMA-treated patients were hypertension, fatigue, diarrhea, decreased appetite, arthralgias or myalgia, decreased weight, abdominal pain, PPE, proteinuria, dysphonia, hemorrhagic events, hypothyroidism, and nausea. So Alana, how do you monitor patients for ARs when starting LENVIMA?
Well, of course, it's important to monitor patients throughout their course of treatment for adverse reactions, but it's also important to recognize key points in treatment when adverse reactions are most likely to emerge. This post-hoc analysis of time to first onset of select adverse reactions visually depicts the median time in weeks of onset for select ARs in LENVIMA-treated patients, which was performed during the REFLECT trial. The bars represent the onset of the AR for the middle 50% of patients who experience the AR, and from quartiles 1 and 3, respectively. The median weeks to first onset for each AR is highlighted prominently by the circle marker. Each patient is different, and the median time to onset may not reflect the clinical reality. Patients should be monitored for ARs throughout treatment with LENVIMA. This post-hoc exploratory analysis is for descriptive purposes only. No conclusions can be drawn.
Alana, how do you speak with patients about watching for adverse reactions?
Really, the main take-home that I want patients to leave with is to call us if they've noticed anything different. I do go through the different possible adverse reactions with a new treatment, but those first visits where they're starting a new treatment, I feel like they're taking in so much information that if they're going to leave with one thing, that's what I want it to be, is call us with anything different.
That's absolutely true. I know when I first meet with the patients, there's so much information to go over. And so I tell them about the things to look out for, but then it really helps to have that reinforcement and to have that frequent contact. The LENVIMA prescribing information includes information on the recommended dose and strategies on how to dose modify, including interruptions, reductions, and/or discontinuation. Less than 60 kilograms recommended dose is 8 milligrams once daily. The first dose reduction is to 4 milligrams once daily. A second dose reduction to 4 milligrams once every other day. For greater than or equal to 60 kilograms, the recommended dose is 12 milligrams once daily. The first dose reduction is down to 8 milligrams once daily. The second dose reduction to 4 milligrams once daily, and then the third dose reduction to 4 milligrams once every other day. When I first meet a patient, I start by telling them all the important details about their diagnosis and what to expect. But then when we start talking about treatment, I go over all of the potential side effects and logistics of their treatment. I really value the team that we have and working with advanced practitioners like yourself, I always introduce that this is going to be a team effort. And I always make it my policy to have them see you on their first visit to talk about how their experience is.
Yeah, I think our model works really well because they get that initial kind of laying of the groundwork from you to really understand the key aspects of their diagnosis. And then when I see them, maybe they have another level of questions that I'm able to address and then can really start more of an ongoing conversation about AR management.
Thank you again, Alana, for sharing your insights with us today.
Thank you, Dr. Kim. I'm glad to be here.
Please stay tuned for additional selected safety information.
Hypertension. In DTC, differentiated thyroid cancer, hypertension occurred in 73% of patients on LENVIMA, 44% grade 3 to 4. In RCC, renal cell carcinoma, hypertension occurred in 42% of patients on LENVIMA plus everolimus, 13% grade 3. Systolic blood pressure greater than or equal to 160 millimeters of mercury occurred in 29% of patients, and 21% had diastolic blood pressure greater than or equal to 100 millimeters of mercury. In HCC, hepatocellular carcinoma, hypertension occurred in 45% of LENVIMA-treated patients, 24% grade 3. Grade 4 hypertension was not reported in HCC. Serious complications of poorly controlled hypertension have been reported. Control blood pressure prior to initiation. Monitor blood pressure after 1 week, then every 2 weeks for the first 2 months, and then at least monthly thereafter during treatment. Withhold and resume at reduced dose when hypertension is controlled or permanently discontinue based on severity. Cardiac dysfunction. Serious and fatal cardiac dysfunction can occur with LENVIMA. Across clinical trials in 799 patients with DTC, RCC, and HCC grade 3 or higher, cardiac dysfunction occurred in 3% of LENVIMA-treated patients. Monitor for clinical symptoms or signs of cardiac dysfunction. Withhold and resume at reduced dose upon recovery, or permanently discontinue based on severity. Arterial thromboembolic events. Among patients receiving LENVIMA or LENVIMA plus everolimus, arterial thromboembolic events of any severity occurred in 2% of patients in RCC and HCC, and 5% in DTC. Grade 3 to 5 arterial thromboembolic events ranged from 2% to 3% across all clinical trials. Among patients receiving LENVIMA with pembrolizumab, arterial thrombotic events of any severity occurred in 5% of patients in CLEAR, including myocardial infarction, 3.4%, and cerebrovascular accident, 2.3%. Permanently discontinue following an arterial thrombotic event. The safety of resuming after an arterial thromboembolic event has not been established, and LENVIMA has not been studied in patients who have had an arterial thromboembolic event within the previous 6 months. Hepatotoxicity. Across clinical studies enrolling 1,327 LENVIMA-treated patients with malignancies other than HCC, serious hepatic adverse reactions occurred in 1.4% of patients. Fatal events, including hepatic failure, acute hepatitis, and hepatorenal syndrome, occurred in 0.5% of patients. In HCC, hepatic encephalopathy occurred in 8% of LENVIMA-treated patients. 5% grade 3 to 5. Grade 3 to 5 hepatic failure occurred in 3% of LENVIMA-treated patients. 2% of patients discontinued LENVIMA due to hepatic encephalopathy, and 1% discontinued due to hepatic failure. Monitor liver function prior to initiation, then every 2 weeks for the first 2 months, and at least monthly thereafter during treatment. Monitor patients with HCC closely for signs of hepatic failure, including hepatic encephalopathy. Withhold and resume at reduced dose upon recovery, or permanently discontinue based on severity. Renal failure or impairment. Serious, including fatal renal failure or impairment, can occur with LENVIMA. Renal impairment was reported in 14% and 7% of LENVIMA-treated patients in DTC and HCC, respectively. Grade 3 to 5 renal failure or impairment occurred in 3% of patients with DTC and 2% of patients with HCC, including 1 fatal event in each study. In RCC, renal impairment or renal failure was reported in 18% of LENVIMA plus everolimus-treated patients, 10% grade 3. Initiate prompt management of diarrhea or dehydration or hypovolemia. Withhold and resume at reduced dose upon recovery or permanently discontinue for renal failure or impairment based on severity. Proteinuria. In DTC and HCC, proteinuria was reported in 34% and 26% of LENVIMA-treated patients, respectively. Grade 3 proteinuria occurred in 11% and 6% in DTC and HCC, respectively. In RCC, proteinuria occurred in 31% of patients receiving LENVIMA plus everolimus, 8% grade 3. Monitor for proteinuria prior to initiation and periodically during treatment. If urine dipstick proteinuria greater than or equal to 2+ is detected, obtain a 24-hour urine protein. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Diarrhea. Of the 737 LENVIMA-treated patients in DTC and HCC, diarrhea occurred in 49%, 6% grade 3. In RCC, diarrhea occurred in 81% of LENVIMA plus everolimus-treated patients, 19% grade 3. Diarrhea was the most frequent cause of dose interruption or reduction, and diarrhea recurred despite dose reduction. Promptly initiate management of diarrhea. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Fistula formation and gastrointestinal perforation. Of the 799 patients treated with LENVIMA or LENVIMA plus everolimus in DTC, RCC, and HCC, fistula or gastrointestinal perforation occurred in 2%. Permanently discontinue in patients who develop gastrointestinal perforation of any severity or grade 3 to 4 fistula. QT interval prolongation. In DTC, QT or QTC interval prolongation occurred in 9% of LENVIMA-treated patients, and QT interval prolongation of greater than 500 milliseconds occurred in 2%. In RCC, QTC interval increases of greater than 60 milliseconds occurred in 11% of patients receiving LENVIMA plus everolimus, and QTC interval greater than 500 milliseconds occurred in 6%. In HCC, QTC interval increases of greater than 60 milliseconds occurred in 8% of LENVIMA-treated patients, and QTC interval greater than 500 milliseconds occurred in 2%. Monitor and correct electrolyte abnormalities at baseline and periodically during treatment. Monitor electrocardiograms in patients with congenital long QT syndrome, congestive heart failure, bradyarrhythmias, or those who are taking drugs known to prolong the QT interval, including Class 1A and 3 antiarrhythmics. Withhold and resume at reduced dose upon recovery based on severity. Hypocalcemia. In DTC, grade 3 to 4, hypocalcemia occurred in 9% of LENVIMA-treated patients. In 65% of cases, hypocalcemia improved or resolved following calcium supplementation with or without dose interruption or dose reduction. In RCC, grade 3 to 4, hypocalcemia occurred in 6% of LENVIMA plus everolimus-treated patients. In HCC, grade 3 hypocalcemia occurred in 0.8% of LENVIMA-treated patients. Monitor blood calcium levels at least monthly and replace calcium as necessary during treatment. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity. Reversible posterior leukoencephalopathy syndrome, RPLS. Across clinical studies of 1,823 patients who received LENVIMA as a single agent, RPLS occurred in 0.3%. Confirmed diagnosis of RPLS with MRI. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity and persistence of neurologic symptoms. Hemorrhagic events. Serious, including fatal hemorrhagic events, can occur with LENVIMA. In DTC, RCC, and HCC clinical trials, hemorrhagic events of any grade occurred in 29% of the 799 patients treated with LENVIMA as a single agent or in combination with everolimus. The most frequently reported hemorrhagic events, all grades and occurring in at least 5% of patients, were epistaxis and hematuria. In DTC, grade 3 to 5, hemorrhage occurred in 2% of LENVIMA-treated patients, including one fatal intracranial hemorrhage among 16 patients who received LENVIMA and had CNS metastases at baseline. In RCC, grade 3 to 5 hemorrhage occurred in 8% of LENVIMA plus everolimus-treated patients, including one fatal cerebral hemorrhage. In HCC, grade 3 to 5 hemorrhage occurred in 5% of LENVIMA-treated patients, including 7 fatal hemorrhagic events. Serious tumor-related bleeds, including fatal hemorrhagic events, occurred in LENVIMA-treated patients in clinical trials and in the post-marketing setting. In post-marketing surveillance, serious and fatal carotid artery hemorrhages were seen more frequently in patients with anaplastic thyroid carcinoma, ATC, than other tumors. Safety and effectiveness of LENVIMA in patients with ATC have not been demonstrated in clinical trials. Consider the risk of severe or fatal hemorrhage associated with tumor invasion or infiltration of major blood vessels, e.g., carotid artery. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Impairment of thyroid-stimulating hormone suppression or thyroid dysfunction. LENVIMA impairs exogenous thyroid suppression. In DTC, 88% of patients had baseline thyroid-stimulating hormone, TSH level, less than or equal to 0.5 milliunits per liter. In patients with normal TSH at baseline, elevation of TSH level greater than 0.5 milliunits per liter was observed post-baseline in 57% of LENVIMA-treated patients. In RCC and HCC, grade 1 or 2 hypothyroidism occurred in 24% of LENVIMA plus everolimus-treated patients and 21% of LENVIMA-treated patients, respectively. In patients with normal or low TSH at baseline, elevation of TSH was observed post-baseline in 70% of LENVIMA-treated patients in HCC and 60% of LENVIMA plus everolimus-treated patients in RCC. Monitor thyroid function prior to initiation and at least monthly during treatment. Treat hypothyroidism according to standard medical practice. Impaired wound healing. Impaired wound healing has been reported in patients who received LENVIMA. Withhold LENVIMA for at least 1 week prior to elective surgery. Do not administer for at least 2 weeks following major surgery and until adequate wound healing. The safety of resumption of LENVIMA after resolution of wound healing complications has not been established. Osteonecrosis of the jaw, ONJ. ONJ has been reported in patients receiving LENVIMA. Concomitant exposure to other risk factors, such as bisphosphonates, denosumab, dental disease, or invasive dental procedures, may increase the risk of ONJ. Perform an oral examination prior to treatment with LENVIMA and periodically during LENVIMA treatment. Advise patients regarding good oral hygiene practices and to consider having preventive dentistry performed prior to treatment with LENVIMA and throughout treatment with LENVIMA. Avoid invasive dental procedures if possible while on LENVIMA treatment, particularly in patients at higher risk. Withhold LENVIMA for at least 1 week prior to scheduled dental surgery or invasive dental procedures if possible. For patients requiring invasive dental procedures, discontinuation of bisphosphonate treatment may reduce the risk of ONJ. Withhold LENVIMA if ONJ develops and restart based on clinical judgment of adequate resolution. Embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to pregnant women. In animal reproduction studies, oral administration of lenvatinib during organogenesis at doses below the recommended clinical doses resulted in embryo-toxicity, fetotoxicity, and teratogenicity in rats and rabbits. Advise pregnant women of the potential risk to a fetus and advise females of reproductive potential to use effective contraception during treatment with LENVIMA and for 30 days after the last dose. Adverse reactions. In HCC, the most common adverse reactions, greater than or equal to 20%, observed in LENVIMA-treated patients were hypertension, 45%, fatigue, 44%, diarrhea, 39%, decreased appetite, 34%, arthralgia or myalgia, 31%, decreased weight, 31%, abdominal pain, 30%, Palmer-Plantar erythrodysesthesia syndrome, 27%, proteinuria, 26%, dysphonia, 24%, hemorrhagic events, 23%, hypothyroidism, 21%, and nausea, 20%. The most common serious adverse reactions, greater than or equal to 2%, were hepatic encephalopathy, 5%, hepatic failure, 3%, ascites, 3%, and decreased appetite, 2%. Adverse reactions led to dose reductions or interruption in 62% of patients. The most common adverse reactions, greater than or equal to 5%, resulting in dose reductions were fatigue, 9%, decreased appetite, 8%, diarrhea, 8%, proteinuria, 7%, hypertension, 6%, and Palmer-Plantar erythrodysesthesia syndrome, 5%. Treatment discontinuation due to an adverse reaction occurred in 20% of patients. The most common adverse reactions, greater than or equal to 1%, resulting in discontinuation of LENVIMA were fatigue 1%, hepatic encephalopathy 2%, hyperbilirubinemia 1%, and hepatic failure 1%. Use in specific populations. Because of the potential for serious adverse reactions in breastfed children, advise women to discontinue breastfeeding during treatment and for 1 week after last dose. LENVIMA may impair fertility in males and females of reproductive potential. No dose adjustment is recommended for patients with mild creatinine clearance CLCR 60 to 89 milliliters per minute or moderate CLCR 30 to 59 milliliters per minute renal impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or endometrial carcinoma, EC, and severe CLCR 15 to 29 milliliters per minute renal impairment. Reduce the dose for patients with DTC, RCC, or EC, and severe renal impairment. There is no recommended dose for patients with HCC and severe renal impairment. LENVIMA has not been studied in patients with end-stage renal disease. No dose adjustment is recommended for patients with HCC and mild hepatic impairment, Child-Pugh A. There is no recommended dose for patients with HCC with moderate Child-Pugh B or severe Child-Pugh C hepatic impairment. No dose adjustment is recommended for patients with DTC, RCC, or EC and mild or moderate hepatic impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC and severe hepatic impairment. Reduce the dose for patients with DTC, RCC, or EC and severe hepatic impairment.